So when it comes to combination therapy, is there a sequence that you give them in the treatments, or do they all come in at once?
No, the sequence usually, of course, is men that have been checking their PSA every 3 to 6 months, and now it's going up, is to first get as good a scan as you can get, a PSMA PET scan or maybe an axonome PET scan, to establish that there is a metastatic lesion. There's with androgen independence, castrate resistance, there's almost always a metastatic lesion somewhere, but we may not be able to find it if it's very early stage, and the better the scan, the more likely you will be in your capacity to find it. Finding that spot is important if combination therapy is anticipated, because that's the way you get insurance coverage for Provenge, which sort of kicks off the whole process. So once a metastatic lesion is established, we usually give them Provenge, which only takes about 6 weeks. And then we can start them thereafter on a combination of Keytruda and Xtandi. We tend to pick Xtandi over Zytiga in this situation because there's some soft information, some soft data suggesting that Xtandi also stimulates the immune system a little bit. So we start the Keytruda and the Xtandi at the same time. And then once the Xtandi gets started, of course, PSAs plummet down to undetectable levels. And we continue the Keytruda for a variable period of time. Longer and longer treatment periods can incur more side effects. So there's a sort of a balancing act in terms of what optimal treatment period is. No one really knows. But we typically don't go indefinitely with it. 3 to 6 to 9 months would probably be a reasonable time period. And then the patients do continue on the Xtandi indefinitely, and we observe patients staying in remission for years with this type of approach.
So in a case where a man has, had a scan, they've seen a spot, they decide to radiate it, are you going to radiate it in order to get the abscopal effect? Is it that immune activity that we're looking for?
So yeah, the abscopal effect's a fascinating phenomena that when you radiate a spot of cancer in the body, and it kills that cancer, the immune system then can come in, clean up the debris, and then learn about the structural makeup, the types of proteins that are in the cancer, and then it can go around and attack cancers in other part of the body. So the primary reason to radiate a spot is to just sterilize the spot and kill off the known cancer. But we always suspect that there are other smaller tumors lurking in other parts of the body that are too tiny to be detected by the scan. And of course, we're hoping that the Provenge and the Xtandi will get rid of it. But by radiating that one spot, we also believe that we're cluing the immune system in to attack those other small spots, and that's what you're calling the abscopal effect. And it is a real phenomenon. It's not a consistent finding, but perhaps in 10-20% of patients, you'll see who have known spots, visible spots, you'll see shrinkage in those spots without any other treatment than just radiating the original spot. That's called the abscopal effect. And it does have an enhancing effect on immunity, and probably does work in conjunction with these other things like Provenge and Keytruda.
So does the abscopal effect happen with any type of radiation to the bone?
Yes, indeed. It probably can, although they believe that fast radiation that kills the cancer quickly is probably inciting a greater abscopal effect than little bits of radiation that go in over a long period of time. So the fastest radiation is either CyberKnife or SBRT, which is favored also for convenience reasons, so people don't have to go back and get a bunch of visits to the radiation therapist. They can get their treatment over quickly.
And does the abscopal effect also happen in lymph nodes as well as bone? Does it matter where the metastatic lesion is?
As far as we know, it's the same in all locations.
I personally find immune therapy is really fascinating because it's not like a chemical or radiation or something coming into the body and killing the cancer. It's actually your immune system killing the cancer. So that's really exciting technology. I know this was discovered, the PD-1, which is, the whole mechanism of what they're blocking in order for the cancer to be unmasked and the immune system to be able to identify it as cancer. So how will this technology shape prostate cancer treatments in the future?
Well, one of the things we have, there's more research in trying to determine who's going to respond and who is going to develop side effects. So I think going forward, we'll be able to pick medicines for the kind of results that we expect to get. Right now, everything is sort of a trial and error situation. And then, of course, what's changing is the idea of using these medicines in combination. Combination therapy has been the pathway to more successful outcomes in all kinds of cancers, infectious disease, treatment of heart disease with multiple medicines, the same thing is going to be true for immune therapy.
Thank you for watching. If you would like more information about anything that we spoke about today, you can visit our website, PCRI.org. Also, please subscribe to our YouTube channel. We come out with new prostate cancer videos every week.